Greetings, everybody. My name is Aishwarya. I'm a board-certified genetic counselor. Today, I will be presenting my abstract, which is titled, Is Double Heterozygosity in BRCA Genes Incompatible with Life? This case study revolves around the concept known as double heterozygosity, which is also called as the transheterozygosity. This is a rare genetic finding in which two genes, in this context, we have BRCA1 and BRCA2, that have heterozygous variations in them. So the estimated rate for this is around 0.22 to 0.83% in non-Ashkenazi Jewish women, whereas this percentage can go as high as 1.8% in Ashkenazi Jewish population. The very first instance of a double heterozygosity in BRCA gene was reported in an Hungarian patient with breast and ovarian cancer in the year 1997. So the case study that I will be presenting today is of a female proband who was aged 52 years old. She was diagnosed with high-grade serous ovarian cancer at 52 years of age. She presented with abdominal distension and ascitic fluid accumulation. Her treatment history included 3 cycles of neoadjuvant chemotherapy with a cytoreductive surgery being planned. She had a previous surgical history, which included a thyroidectomy done for her benign gout around 20 years ago. Her menstrual history were regular. She did not have any environmental or industrial exposure. However, she did present with a family history, wherein her sister was diagnosed with breast cancer at 32 years of age, and her mother was diagnosed with ovarian cancer at 52 years of age. All of these patient profile details are represented in the form of a pedigree to the left side of the abstract. So given the patient profile, the clinician recommended a hereditary BRCA1/2 test for the patient. So there was a very interesting finding which reported 2 heterozygous pathogenic variants in both of these genes. One variant was seen in BRCA1 in the exon 10 region, and it was seen that this variant causes a frame shift mutation, leading to the premature termination of the protein, which lacked major functional domains, rendering the protein having loss of function. At the same time, there was another pathogenic variant detected in intron 2 of BRCA2 gene, and it was predicted that this variant is likely to impede the splicing at the junction of exon 2 and intron 2 of BRCA2 gene. So based on all of these clinical details, once the clinician went through the details of the report, he had suspicions about the compatibility of these mutations with life. This prompted a post-test genetic counseling session with the patient. So in the session, we addressed all of these concerns, and alongside, we explained the concept of double heterozygosity, its prevalence, and the need for appropriate surveillance to manage the risk. Furthermore, a cascade testing was recommended for the proband's first degree relative to determine if or not they harbor the same BRCA variants. So the takeaway from this case is the importance of both pre and post-test genetic counseling session. This test also sheds light on the prevalence of a double heterozygosity variants in BRCA genes in non-Ashkenazi Jewish populations, such as the Indian population. And it also does help us understand the need for genetic testing and how it should go beyond identifying single gene variants to ensure that there is a thorough analysis of multiple susceptibility genes. Thank you.